be cardiac in origin. Then retinal arteriitis, inflammation of the walls of the retinal arteries with obliteration. Then spasm of the arteries is a rare cause of retinal artery occlusion. It is commonly associated with amaurosis, blindness. The clinical features in arterial occlusion depends on the size and location of the obstructed vessels and the severity and duration of the obstruction. Central retinal artery occlusion. Patients complaints of sudden, painless, and profound loss of vision. Direct pupillary light reflex is absent. Ophthalmoscopy shows the following signs. The retina appears white as the result of cloudy swelling caused by intracellular edema. Central part of the macular area shows cherry red spot due to a vascular choroid shining through the thin retina of this region. Retinal arteries are narrowed. After a few weeks, the edema subsides and atrophic changes occur, retinal gliosis or even optic atrophy. Here you see these cherry red spot symptoms. Cornea really looks in this area whitish, cloudy whitish, and this fovea centralis of the yellow spot looks reddish, cherry red spot symptoms. Treatment of major retinal artery occlusion is aimed at restoring the retinal circulation as quickly as possible by increasing retinal perfusion and dislodging emboli. Retinal tissue cannot survive ischemia for more than a few hours. The emergency treatment should include retrobulbar injection of atropine sulfate, 0.1 intravenous, euphilinum solution, 2.4%, then several other drugs which we use to dilate the blood vessels, retrobulbar intramuscular injections, and so on. Inhalation of mixture of 5% carbon dioxide and 95% oxygen is possible to use for the same purpose. A lowering of intraocular pressure is necessary. Treatment includes vasodilators, anticoagulants. Steroids are indicated in patients with Guyan cell arteritis. Complications. In some cases, neovascular glaucoma may occur as a delayed complication of central retinal artery occlusion. Neovascular glaucoma means glaucoma due to the presence, due to development of the blood vessels, abnormal blood vessels in the angle of the anterior chamber as a result of the ischemia of the anterior chamber. And if you see the patient with such a glaucoma, you see blood vessels on the surface of the iris. Normally, there must be no such vessels in this area. Treatment of neovascular glaucoma is rather difficult. It's a sort of refractory glaucoma, and usually surgery with implantation of different devices, tubes are necessary in this case. Retinal vein occlusion. After diabetic retinopathy, retinal vein occlusion is the most common retinal disease. The predisposing factors include increase in age, patient in the 6th and 7th decades of life, systemic hypertension, angiosclerosis, atherosclerosis, diabetes mellitus, sometimes focal or general infections, sepsis, pneumonia, and so on and so forth. It refers to sudden complete occlusion of central retinal vein. It is characterized by marked sudden visual loss, Fundus examination reveals severe optic disc edema and hyperemia. Extensive retinal hemorrhages. Almost whole fundus is full of hemorrhages, giving a splashed tomato appearance. And judgment and marked changes of the retinal veins, numerous of soft exudates. Here you see a photo of this patient with severe a lot of severe hemorrhages, huge hemorrhages in different areas of the superior retina. We can suggest that this is not the full occlusion of the full thrombosis of the central retinal vein, but partial, only of its part. We think that this is the temporal superior branch of the central retinal vein occlusion. Emergency treatment. Of course, control of hypertension, it's clear. Anticoagulants. Then we can use spasmolytics, steroids, photocoagulation, laser surgery to prevent the same complication like in case of arterial obstruction, I mean the neovascular glaucoma. I'd like to say that our treatment in case of arterial obstruction is effective and we have a chance for recovery of visual functions only if we start our treatment in first 2 hours after the occlusion. The same situation with thrombosis. Prognosis in both cases, prognosis for the visual function is doubtful, and there exists a high risk of optic nerve atrophy development with a irreversible loss of visual functions. Among the other complications in case of retinal vein thrombosis are vitreous hemorrhages and proliferative retinopathy, development of the growth of the connective tissue with the risk of tractional retinal detachment and so on. The next group of drugs, next group of disorders are inflammatory disorders of the retina. These may present as retinitis, pure retinal inflammation, chororetinitis, inflammation of retina and choroid, neuroretinitis, inflammation of optic disc and surrounded retina, or periphlebitis retina, inflammation of the retinal vessels. Central serous retinopathy. It is characterized by spontaneous detachment of neurosensory retina in the macular region, which apparently appears as macular edema. Etiology isn't known exactly. It is typical affects males between 20 to 40 years. The neurosensory retina is elevated due to collection of fluid underneath owing to a defect in the retinal pigment epithelium. Patient's complaints. Dark spot in front of the eye. It may present with a sudden onset of painless loss of vision associated with positive scotoma, defects inside the visual field. My patient's complaints in case of positive scotoma on a black spot or dot in front of his eyes. Micropsia and metamorphopsia. Micropsia means decreasing size of the surrounded objects. Metamorphopsia when the direct lines looks curved due to the edema and other changes of the retina. During the ophthalmoscopy, we can see mild elevation of macular area demarcated by a circular ring reflex. Here you see it, line of demarcation. Focus has a grayish color and different size. Here it's rather huge, central serous retinopathy. Central serous retinopathy is often recurrent. It often leaves small areas of atrophy, areas of depigmentation. Sometimes we can determine peripheral localization of the focus, not in the central part, on the periphery. It's more benign type because the central vision in this case is normal. Fluorescein angiography helps to determine correct diagnosis. Treatment depends on etiology. We can use steroids, like the most effective in this case group of drugs, vitamins and vasodilators. Some authors think that the effectiveness of these groups of drugs are doubtful. Antihistamine drugs, and in long-standing case, we can use even laser coagulation. One more severe disorder of the eye associated with the retinal damage is Eales disease or retinal periphlebitis, inflammation around or near the or along the walls of the retinal veins. It is idiopathic inflammation of the peripheral retinal veins. It is characterized by recurrent vitreous hemorrhages. Etiology, unfortunately, is not known exactly. It is a bilateral disease, typically affecting young adult males. The common presenting symptoms are sudden appearance of floaters, black spots, in front of the eye or painless loss of vision due to vitreous hemorrhage. In the early stages, the affected veins are congested and show sheathing. Superficial retinal hemorrhages may be present near the affecting veins. In later stages, recurrent vitreous hemorrhages may be associated with retinal neovascularization, development of the new pathological blood vessels. Complications of this disorder include proliferative retinopathy, growth of the connective tissue, tractional retinal detachment, rubeosis iridis, and neovascular glaucoma, growth of the new pathological blood vessels on the surface of the iris. Then when they get the angle of the anterior chamber and decrease the outflow of the aqueous humor, this condition is associated with the neovascular glaucoma. Treatment: oral and local steroids. Sometimes, if we know the exact etiology, for example, tuberculosis may cause such a condition, we can use antitubercular treatment, vitamins, laser photocoagulation, like maybe the most effective way to stop the recurrent intravitreous hemorrhages. And if there is no spontaneous resorption of this blood from the vitreous body, we can use surgical treatment, vitrectomy, to remove the blood from the vitreous cavity. So, retinal detachment. I have already repeated several times these words today, especially when we were talking about the diabetic changes in form of tractional retinal detachment. But there exist different types of retinal detachment. The retinal detachments means separation of the sensory retina from retinal pigment epithelium. Pathogenesis. In retinal detachment, non-tractional retinal detachment, fluid collects in the potential space between the sensory retina and the retinal pigment epithelium. Fluid may accumulate by three major mechanisms. It may escape from the vitreous cavity into the subretinal space through a retinal hole or tear or break in the retina. This tear is called rhumatogenous, primary retinal detachment. Extravasation from the choroid or the retina may result in retinal detachment in the absence of a tear or traction. the so-called secondary retinal detachment. Lastly, the retina can be detached from its normal position by fibrous bands in the vitreous, resulting in attractional retinal detachment. Predisposing factors of primary retinal detachment are high myopia, aphakia, means absence of the crystalline lens in its normal position, maybe congenital or acquired or post-traumatic, for example, or after the surgery. Different types of retinal degenerations and trauma. Clinical features. Patients notice a localized relative loss in the field of vision, which progress to a total loss when peripheral detachment proceeds gradually towards the macular luther. In this stage, maybe photopsia, looks like for the patient like flashes of light, and floaters, like black spots, black flies in front of the patient eye. During the ophthalmoscopy, on examination, detached retina gives gray reflex instead of normal pink reflex and is raised anteriorly. There may be small or may assume the shape of balloons in large bullous retinal detachment. The retina blood vessels appear darker than in flat retina. Retinal holes look reddish in color and vary in shape. They may be round, horseshoe-shaped, slit-like. Associated retinal detachment, associated retinal degeneration and hemorrhages may be discovered. Visual field charting reveals scotomas corresponding to the area of detached retina. And ultrasonography, very important method of examination, can confirm the diagnosis. So ophthalmoscopy and ultrasonography can help us to determine the position of the detached retina, areas of the detached retina. With the help of ophthalmoscopy, we can find breaks in the retina and to determine their amount, their position, and so on. Treatment of retinal detachment is only surgical. Here you see another type of retinal detachment. It's a tractional retinal detachment. We can't see even optic nerve disc. We know it's somewhere here, but in front of the disc and in front of the retina, you see the connective tissue membrane, which cover it. And of course, in this case, it's necessary to remove these membranes because they detached the retina in the vascular arcades in this area, in the central part and the peripheral part, and without treatment, prognosis for the visual functions and even for the eyeball as an organ is doubtful. So what are the principles of retinal detachment treatment? Several words about the possible complications: proliferative retinopathy, complicated cataract, opacity of the crystalline lens, uveitis, inflammation of the uveal tract, and phthisis bulbae, when the eyeball decreased in size, it's sort of shrinking in with the hypothony, with a small intraocular pressure, with the loss of all the visual functions, and the risk of the development of sympathetic ophthalmitis. In this case, it's necessary to remove the eyeball to prevent more severe complications, which can involve the normal eye. So, basic principles of surgical treatment. It may be sealing of the retinal breaks by cryocoagulation, low temperature coagulation, or photocoagulation, or diathermy by producing aseptic inflammation. And bringing another way of treatment is bringing the choroid and detached retina near to each other, the so-called procedure of scleral buckling. and explant these materials sutured directly onto sclera to create a buckle. And the most effective nowadays way of treatment of retinal detachment is vitrectomy. When we remove the vitreous body, when we remove the subretinal liquid from the retina, put the retina to its normal position, use the laser to fix the retina in its normal position, and then make a tamponade of the vitreous cavity by silicone oil or special ophthalmic gas. Secondary detachment may be of different causes. It may be exudative and may be tractional. Exudative retinal detachment, its commonest causes can be grouped as systemic disease, for example, retinal hypertension, toxemia, or even pregnancy. Or ocular diseases, inflammation, vascular diseases like central serous retinopathy, which we have already discussed, neoplasm tumors. It may be differentiated from a simple detachment, primary detachment, by absence of photopsia, absence of holes, tears, absence of folds, and undulation. At the summit of tumors, it is usually rounded and fixed and may show pigmentary disturbance. Tractional retinal detachment, already discussed before, is associated with post-traumatic reaction or scar tissue of proliferative diabetic retinopathy, retinal vein thrombosis, and several other disorders. It is characterized by presence of vitreoretinal bands with damage with the presence of the causative disease. And final subtopic for today is tumors of the retina. Retinoblastoma. It is a common congenital malignant tumor arising from the sensory layer of retina in one or both eyes. It is the most common intraocular tumor of childhood. Untreated, it is almost invariably almost fatal. It may arise in two ways. Sporadic cases as the result of somatic mutation. These are usually unilateral. And familial cases occur by autosomal dominant inheritance. Most of cases tend to be bilateral in case of familial retinoblastoma. Clinical features. Retinoblastoma can be divided into 4 stages. It is usually recognized at birth or between 1 to 2 years. One of the first symptoms, yellowish-white pupillary reflex, may be squint, and defective vision. Here you see the patient with retinoblastoma, and instead of normal red reflex, you'll see the yellowish or whitish or grayish reflex from the fundus, which is the symptom of this severe disorder, and the parents can see it and come with this newborn to the doctor. Ophthalmoscopy. Tumor looks like a well circumscribed polypoid mass of white or maybe a bit even pinkish in color. There may be multiple growths projecting into the vitreous body. The second stage, the so-called glaucoma stage, glaucomatous stage, which is associated with the severe pain, redness, and watering. We have no such symptoms in early stage, so in this case only the abnormal fundus reflex and problem with the visual functions may help us to put the correct diagnosis. And then we use a special examination with ultrasound and so on. And of course, we can determine it more thoroughly. But in the second stage, it's severe pain, redness, and water. And of course, such a newborn is crying all the time. Eyeball is enlarged. Conjunctiva is congested, means with dilated blood vessels, and intraocular pressure is raised. Stage of extraocular extension. The next stage, the globe bursts through the sclera, and you can find the growth of the tumor out of the outer coat of the eyeball. A final stage of distant metastatic by lymphatic spread in direct extension or metastasis by blood. The target organs are brain, lungs, liver, and bones. Treatment. Treatment of retinoblastoma is surgical, or in some case we use chemotherapy or radioactive therapy if it's a small tumor and if it's possible to save the eyeball as an organ. So in most of patients with advanced stage, we use enucleation. It is the treatment of choice with post-operative radiotherapy because it's rather aggressive tumor. Enucleation means removing of the eyeball from its normal place, so we just remove it. And tumor destructive therapy is possible in early stage when the size of the tumor is not so large. Radiation therapy, photocoagulation or cryocoagulation of the tumor, scleral plaques, when we put the radioactive elements on the surface of sclera in the place of tumor basis development. And sometimes it's possible to destruct the tumor by radioactive therapy by use of these scleral plaques containing radioisotopes. Prognosis for the eyeball is doubtful. For the patient's life is also doubtful, as you understand. But in early stage, if we manage to put the correct diagnosis in early stage, it's sometimes possible to prevent such a poor and such a sad result, final result. That's all for today. Thank you for your attention. If you have any questions, let's discuss them now.